Hello friends and good evening. Today we will see some recall questions of FMGE which we had recently completed 4-5 days back. We took a bit of more time than what is normal because I wanted to collect the maximum number of questions which is possible so that we try to get a maximum area which can be of use to the next sessions. Okay, so with this idea, we will just see the comments and any. We will have around 5 to 7 questions this time, and we will see how these questions have to be appeared. The questions were rather simple this time, and that is what we were expecting also. Okay, straight away we will go to the questions, and if you have any doubts, please send us the question. We will have a live chat, or you can ask in between, not an issue. Okay, so let us see the first question. Yeah, which of the following is a choice of induction in children? This is probably one of the easiest question that we will have in anesthesia, because from the time we started the class, we have been talking about the how to induce a child, and it is always given with the code. I hope you remember. For sweet children, we use sweet sevoflurane. So that is a code which we can always use for induction. Now we have 4 options. We will see how we can differentiate between them. Now, I don't have any confusion with desflurane nor isoflurane. The only option regarding volatile agent used for induction is only halothane and sevoflurane. Now, how to differentiate? The halothane was probably one of the best thing which I have used, which we have used when we were all started doing practicing, because halothane was the older agent. It had very good advantages that the MAC value is 0.75, which is probably make it a higher potent volatile agent for induction. But unfortunately, it had a lot of issues like hepatitis, then precipitation of malignant hyperthermia, vasodilatation, arrhythmias, etc. So what happened? Gradually, halothane decreased its popularity. Then came sevoflurane, which has increased popularity because it is sweet to smell, reasonably okay MAC value. So you get a easier induction with children. See, isoflurane, although it has got a better value in concern of MAC, isoflurane is not very comfortable for inhalation. It is an irritant, and desflurane is known to be an irritant. So isoflurane and desflurane are basically agents which are used for maintenance of anesthesia, while sevo and halothane were the one which were used for induction, of which halothane is the one which were earlier used. Now it is a time of sevoflurane. So I hope the question is very simple. For children, sevoflurane, sweet sevoflurane for the sweet children. Okay. Now let us see what are the other agents which is used in this area. We should know the MAC values of various volatile agents. This is very commonly, the most commonly asked questions are about halothane, which is 0.75, and then nitrous oxide. Nitrous oxide, as you know, cannot be used as a induction agent because it has got a very high MAC value and it is a very poor agent which is used for induction. Okay, so other values which are commonly asked as isoflurane and sevoflurane. Ether is an older agent. Nowadays we are not using it. Desflurane is another value which you need to study, which is 6.6. Okay, so these are important values which you should understand. So whenever you get such a question, remember the first thing, when you want to induce 2 options, halothane and sevoflurane. Of halothane, arrhythmogenic, now it is sweet sevoflurane for induction in children. This sevoflurane is used not only for induction in children, it is also used for putting cannula in children. Sevoflurane induction for children. So that's a question. Now, come to the second question. Local anesthesia used for intravenous regional anesthesia. You know, intravenous regional anesthesia is a very common topic which we have recently stressed upon, discussed many times, and this is otherwise known as Bayer's block, because it was discovered by a person called August Bayer. It is the same person who discovered subarachnoid block. I hope all these points you remember by the time when you hear this. And which is the best local anesthetic agent which is used for IVRA, which is intravenous regional anesthesia. Now the agent is, it should be not toxic to the body. That is primarily the best choice. Prilocaine is supposed to be the best one, but prilocaine is not in your option. Prilocaine, if you get such a question, you always search for prilocaine, and if prilocaine is not in your option, then your next option is xylocaine. You call it xylocard or loxicard. It is nothing but lignocaine without adrenaline or preservative. So the answer is local anesthetic used for intravenous regional anesthesia is lignocaine without preservative or without adrenaline. Okay, that is most important. But if you have a option of prilocaine, then probably prilocaine would have been the first choice. Okay, prilocaine would have been the first choice. If prilocaine is not there, it is always lignocaine without a preservative. Now, suppose somebody asks you a question, another question. This is probably one of the famous questions that has been repeatedly asked. Bupivacaine is absolute contraindication for IVRA. I hope all of you will remember this. Bupivacaine being a highly cardiotoxic agent with a protein binding of something around 96% is highly cardiotoxic. So we don't use bupivacaine at all for IVRA. Okay, levobupivacaine and ropivacaine are all isomers which are not tried in IVRA. Okay, so that is a second question, which is also a straightforward, simple question. I hope most of you would have got this. Now, this is another very, very simple question. Resistance of endotracheal tube is related to. So the question is, the resistance of the tube shown below is because of. That was a question asked. Okay, I hope you have some question regarding. If you have any other questions regarding this, please let us know. We will discuss on to that. Okay, now resistance on the tube, endotracheal tube, we know it has got very commonly in use radius, curvature, length, and width. Now, if you talk in terms of any tube, the resistance across any tube, the formula is this. It is the Hagen-Poiseuille's law, which says that the resistance, and which basically connect the resistance, the diameter, the pressure drop across, and the viscosity and the length of the tube. Now, the take-home point here is whenever you have a tube, the most important factor which contribute to the resistance is the radius. Okay, so if you reduce the diameter, or if you reduce the radius from, for example, suppose it was 3 centimeters of radius has been reduced by 1 centimeter. Now the resistance increased 16 times because it is inversely proportional to the 4th power of radius. So the most important factor that determines is the radius. Okay, so that is one point which you should remember. Of course, the length of the tube is also there, but not the curvature, as you see in the question. At this juncture, please remember, when the patient is on spontaneous ventilation, this is basically the resistance which we have. The basically 2 to 3 centimeters of water is the resistance which we normally have in our airway. When you put an endotracheal tube, it actually increases the it increases the resistance whenever you put an artificial airway. Yeah, I have got a question. Yeah, very good. This is Mr. Dr. Atul Rahman has given me a question that there was no radius given in the option, only diameter is given in the option. That's perfectly right. I was also in a doubtful whether it was radius. I got few references regarding a few questions from the friends regarding radius and diameter. If you have diameter, it is, as you all know, it is simply the diameter is nothing but the radius into 2. So nothing to worry. If it was diameter, you should have gone to diameter. If it is not diameter, then probably the radius is on, which is directly in the formula. I hope the point is clear with that. Okay, so if it is radius is option. If not, diameter. Okay, it is nothing but twice the radius is the diameter what you get. Now, next question is during neonatal resuscitation, at which heart rate will you start chest compression? That was one question, which I don't know. Many of the people have not conveyed this question to me, but I recently got it from one of my friend who said that there was a question like this. I'm not very sure about this question, whether it was 65 or 60. But then I corrected it to 60. Probably this is the answer because yeah. So this was answer because this is important. I'll show you this. This is a chart. I'm sure that you may not be visualizing it fully, but I'm not intending for that also. I just want you to understand the American Heart Association's guideline of neonatal resuscitation. In neonatal resuscitation, you just need to know two numbers here. That is why this chart has been brought in. The first number which I'm looking at is 100 as a heart rate in neonate. In that condition, what they suggest is look for the chest movement, see for the ventilation, and if needed, put an endotracheal tube. This is for heart rate. Essentially, what they say, when you see the heart rate, look for the respiration and watch. Okay. Suppose it has fallen down to 60, that is heart rate as 60, that is the time where you should start CPR. So that is probably the question what they asked. Okay. Yeah, very good. Answer, Vaibhav, what you said is right. It is 60. So these are the two values which you should remember in this case. Neonatal resuscitation, when you hear such, you have a very high chance to get this question. Whenever you get a question on neonatal resuscitation, look for two numbers. The first number you will be looking at is 100. The second number you will be looking at 60. Okay. If it is 100, watch for the respiration, watch for the vitals, and you should have a close monitoring. And if it is below 60 or 60 and below, go for CPR. So that is another question which we have collected. Okay, so this is about neonatal resuscitation. The fifth question: a patient in ICU with an endotracheal tube now in need of a tracheostomy tube. Which tube will you use? That was a question. Now, obviously, if you see this question of endotracheal tube, anyway, the patient is already on endotracheal tube. We don't have to consider anything about an endotracheal tube nowadays. Now, regarding the next option, metallic tracheostomy tube. Now, metallic tracheostomy tube is nothing but metallic tracheostomy tube was used olden times. Now we don't use metallic tracheostomy tubes. We use only PVC or plastic tracheostomy tubes. Now the question is, how do we go about with this question? I'll just give you the theory. You put a patient on endotracheal tube for some reason on ventilator. We don't use metallic tracheostomy tube. Okay, you put the patient on ventilator. After some times, you feel that this patient cannot be weaned off from the ventilator. This is the word what you are looking at, or the number you are looking at is 2 weeks. So it is, if you want to ventilate a patient within 2 weeks, it's perfectly okay to put the patient on endotracheal tube. Whenever you think that this patient may need longer duration of ventilation, if one arbitrary value which you have kept is 2 weeks, more than 2 weeks, it is better to go with a tracheostomy. Now, why? Because prolonged endotracheal intubation can later cause stenosis, tracheal stenosis, and it is actually a difficult thing to do. So tracheostomy is indicated. That is the area where they have asked the question. A patient in ICU on endotracheal tube now need a tracheostomy tube. What is the type of tube you use? So the key point is, whenever you are putting a patient on positive pressure ventilation, you want the airway to be sealed. You want a definitive airway which goes below the trachea, which goes below the vocal cord, seal the airway so that you can apply positive ventilation of the ventilator, positive pressure ventilator, so that you can inflate the lung. Okay. So in that case, there is no role for uncuffed tube. It is always cuffed tube. And PVC cuffed tracheostomy tube is the standard nowadays. Olden times, metallic tubes were used for malignancy and purpose like that. But again, since it doesn't have a cuff, you don't think about that. So this is rather again a simple question, which most of you would have got through, I'm sure. Okay. Now, I just wanted to share you a few tubes. If you have not got a chance to see this, the first one, what you have is the metallic tubes. You can see an outer tube, an inner tube, and a stillet. This is actually a endotracheal tube which has got a tracheostomy tube which has got a cuff. Okay. And now the third thing what you have is another tube which you should see. This is a tracheostomy tube which has got a fenestration. You can see a fenestration here. This is a fenestrated tracheostomy tube. By any means, suppose you want, somebody is not comfortable to with that and you want to speak, then probably fenestrated tube is an option which you can think about. Anyway, we don't have much question on the type of tracheostomy tube. We should understand that older metallic tubes, nowadays plastic cuffed tracheostomy tube for ventilator. Now, next question. Which device maintain the fraction of oxygen from 0.5 to 1 irrespective of the respiratory effort? Again, this is also a question which has been poorly recollected, but I'll just give you the idea about and the concept behind this. They asked about the FiO2 is as 1 point. So it is very easy if you can recollect the key points which they are striking at. So one is this one, and second is irrespective of the respiratory effort. So 2 points they have mentioned as always. This is the most important thing. One is about the amount of FiO2 a oxygen device can provide is one area they will ask question. The second area they are going to ask question is about the respiratory effort of the patient. So you can otherwise call it as fixed output devices. Okay, fixed output oxygen delivery devices are nothing but these are devices which is going to give you a fixed percentage of oxygen irrespective of the patient effort. So this is the two area which you are going to get a question. Now see the question. Venturi mask. This is an example of fixed output. That means fixed output means it is irrespective of the patient effort. Yeah, let me see. There is nasal cannula given in the option. Okay, we'll come to that. Don't worry. We'll come to that. So that is the one thing. So whenever you want to see an oxygen delivery device, 2 points you should see. One is how much is FiO2. Number two, is it a fixed oxygen delivery device or a something which is depend on patient effort. So among the four things which we have got, Venturi mask is the one which actually give you fixed output condition. Now it can go give you a maximum of 60% of FiO2, or in a way you can say that FiO2 is equal to 0.6. That is 1 point which you should understand. The other things, normal face mask, oxygen cannula, and breathing circuit, partial rebreathing circuit, these are all dependent on patient effort. Of which this area is again a recollection bias can be there, because I don't think this can be an option there. But anyway, since I've recollected it, I thought I'll share it with you. But the point which you should specifically understand is about Venturi mask, because this is an area they keep on asking one or other question sometime in your exam. Okay. Now please see the next question, which you have rightly asked me regarding the nasal cannula. This was probably the question that they asked about the nasal cannula. See, they have asked about what is true about nasal cannula. Now, don't worry about the question, the FiO2, things like that. It is very, very simple. Whenever you see a nasal cannula, there are only two things which you have to understand. I told you, no, whether is it a fixed output device? No, it's not a fixed output device. It depends on patient effort, isn't it? It depends upon patient effort. Second, what is the next thing? How much is FiO2 a nasal cannula can provide? The maximum FiO2 a nasal cannula can provide is 0.45. Okay, so now it is very simple. Now there is, see these questions, these are all what do you call, these are all funny MCQs which they give. It can never be above 100 or 1. So I think there was few recollection about multiple MCQs with more than one, which never happened. Anyway, don't worry about the question per se. You have the concept very clear. When you get an oxygen delivery device, two things: whether it is dependent on patient effort or it is fixed output device. Number two, what is a maximum FiO2? These are the points which you should understand. Anyway, since they have got a question on this, I thought I'll just share a few more points about this. When you have a nasal cannula or nasal prongs, it actually start with 0.24 FiO2 of 0.24 or 24% to a maximum of 0.45 or 45%. This is achieved depending on about how much about a flow that they give. Say starting with 2 liters to maximum of 6 liters that the patient can tolerate. More than 6 liter, there will be total uneasiness for the patient, the dried up secretions. Patient will feel so much of effort, like air gushing into your face. All these are problematic. So remember about 2 points. Nasal cannula, not a fixed device. It is entirely dependent on patient effort. Number two, the maximum amount of FiO2 it can provide is the maximum amount of FiO2 it can provide is 0.45. Okay, so these are the 2 points which you should remember about oxygen delivery device. Oxygen delivery device, nasal cannula. Okay. Now let us see the next question. Now other questions which I've recollected, I didn't get the exact ABCD or the options of that, but I can understand that there are few inputs who have said that they asked about the size of an endotracheal tube is given by. It is essentially by internal diameter. That is one point which you should remember. You call a tube as an 7.5 to 8 or 8 to 8.5, etc. You remember that, no? So these are all the what they say by this number is the internal diameter, which is again an old neat question. Okay, and they have also somebody has recollected that they have also asked a question on the antidote for local anesthetic systemic toxicity. Now I don't specifically recollect whether they have asked about lignocaine or bupivacaine. But anyway, both of things have been discussed. It's very easy. I hope most of you will recollect that also. So see, for example, if it was lignocaine, we all know that it is neurotoxic. Okay, and the treatment was to give thiopentone. Now, if it was bupivacaine, which you call it as local anesthetic systemic toxicity by bupivacaine, the answer is 20% intralipid. Okay, so these are also other areas which I could get few questions, and I thought I'll share it with you so that you don't miss anything for your next exam. So these are all questions that was asked. I hope most of you would have got through this because all these questions have been discussed in our previous things. And thank you, DocTutorials, for providing such a free session for you, which you can recollect anytime. And this will again and again be asked because this is very, very useful and very meticulously arranged, very often expected questions from anesthesia point of view. Okay, thank you. And if you have any doubts, please let me know. We will do it in the chat box. And if you have any queries, you can always connect to me through my Instagram. We will be happy to share those queries. Yeah, these questions, what you have already messaged to me has been, I think we have discussed about this, about the radius option, about the diameter option, and regarding the FiO2 percentage, the heart rate, all these things have been discussed. I hope that will be fine. And if you have anything more, you can definitely get back to me. Okay. Thank you.